Very good evening to all my speakers as well as the viewers. Thanks a lot for sparing your valuable time this evening. I'm extremely thankful and grateful to the beautiful families for sparing you on this Sunday evening. On behalf of Sun Pharma, I am once again privileged and honored to welcome our most awaited, our most respectful, and of course, the most eminent speakers who are considered to be the father in the field of OSA and sleep disorder. Fortunately, today, the 21st June is considered to be Father's Day, so coinciding with Father's Day. Thanks to all fortunate fathers as well. Professor Fredman is from Chicago, USA. Professor Henman is from Germany. And our own Dr. Vijaya Krishnan, who is going to be the moderator of the day. I hope all of you are finding these keynote series very interesting and informative. With this, without further ado, I would now want to kickstart the series 3 of our webinar on IASSA Keynote. With this, over to you, Dr. Krishnan.
Thank you, Mr. Amrish. Good morning, good afternoon, and good evening, one and all. Today, this is our IASSA's Keynote Series 3. Welcome you all. We have two giant leaders in the field of OSA are with us. Professor Karl Hohmann from Germany and Professor Michael Friedman from Chicago, USA. Both of us doesn't need much introduction. So we have two lectures on surgical management on OSA. So first we will be requesting Professor Michael Friedman, who is a consultant ENT and head and neck surgeon from Chicago, USA. He is the chairman of Department of Otolaryngology Head and Neck Surgery at Advocate Illinois Masonic Medical Center, Chicago. He was formerly the professor of otolaryngology and chairman section of sleep surgery at Rush University Medical Center. He was honored as the America's top doctors consistently for the past 20 years by Castle Connolly Medical Guide and by Chicago Magazine's top doctors. He has more than 238 publications in peer-reviewed international journals and 38 textbook chapters and authored 4 textbooks and is also the editor of 13 different international journals. He has special interest in snoring and sleep apnea surgeries, head and neck surgeries, and endoscopic sinus surgeries. He has created many innovative surgical techniques, including our favorite zeta palatal and created many staging systems, which we all know, Friedman's staging for palatal surgery and also tonsil grading, etc., etc. We can keep on telling about him for a day. And without further delay, I would request Professor Michael Friedman to give a talk on search of a surgical solution for OSA. Over to Professor, sir.
Thank you very much. Good evening. And happy Father's Day to all the fathers. So it is part of a customary and many cultures, but certainly in Jewish culture, it's essential that we always start with appreciation for the host. So I want to say a few words about our host, or the host who invited me, Dr. Sagar. This is a picture in 2001. I met Sagar at the academy, who just came up to me and expressed an interest to continue his education in the United States. In a very short time, I saw this ambition and this brilliant mind and this excitement to study and learn. And without a lot of preparation, we decided to create this position, and he became our one of our fellows, and came to Chicago, and we not only developed an amazing relationship, but he continued working continuously with brilliant new ideas, and was able to publish in the short time that he was with us many, many peer-reviewed articles on different topics. While most people in the United States are sleeping on Sunday, I would pick Sagar up at 6:30 in the morning. We'd be on our way to do our research meetings. And he was involved in many of the publications, including Sleep Palatoplasty, that he helped put together the concept of severity of sleep apnea, not predicting the outcome. We did studies on parathyroid hormone. We did studies on snoring. He was involved in endoscopic sinus surgery studies. He was involved in a study on C-reactive protein and studies on Dead Sea salt, which were published and were all hard work by Sagar over day and night by the time he was here. We did studies on laryngeal pharyngeal reflux. He never stopped. When he went back, he continued with clinical fellowship with the good friend Todd Huntley in Indiana, and then went back, as you know, to continued success. I understand he's currently the president of the India Association of Surgeons for Sleep Apnea, and has created innovative tongue-based procedures. So I'm sure that his success will continue, and I'm sure that there'll be more publications and more work that we'll be hearing from. So it is a never-ending battle. The other doctor I wanted to give my thanks to, many, if not all of you, I'm sure know Dr. Venkatesan, who is my son. He wasn't born as my son, but here he is in 1989, when he also came to the United States. Ambitious, brilliant, hardworking. Now, when he first started working for me, he was young, obviously. He claims that I paid him not enough to even buy bread for the week, but it didn't stop him from working hard. He was not only research assistant initially and a fellow and research, but he was my graphic artist with an amazing talent in many, many ways. His talent goes way beyond his surgical skills. So since 1989, he's been by my side, helping, supporting, not only as a colleague, but as a true family member. And he treats me like I'm his dad, and I treat him like my son. His dedication and his genuine love of people is really unmatched. So I thank him for all his years of work and dedication. He's published many things in many areas, including the whole gamut from sinus surgery. We've done work on Kaposi sarcoma, work on other cancer work, and head and neck work, sleep apnea, and he's been involved in almost every new project and every new idea. So we'll talk a little bit about sleep apnea. And I entitled the name of the paper, In Search for a Surgical Cure. And I must say that that search is not complete. I cannot say that we have found the solution. When I started in I started at ENT in 1972, we had we had no treatment for sleep apnea, and we had really very little knowledge about sleep apnea. It wasn't till really there was some work in 1976, but it wasn't until Fujita in 1981 that we all became aware of this surgery, the uvular-pharyngeal palatoplasty, and we became excited. Now, also in the 70s, we had no Cpap. So Cpap was developed around the same time. And we could not imagine that people would use Cpap. So certainly I was excited about the uvular-pharyngeal palatoplasty. I think most ENT doctors in this country and probably all over the world were excited. Between 1981 and 1995, many procedures were done. Patients that had snoring, had sleep apnea, had mild sleep apnea, they had surgery. Many times we didn't even do a sleep study. If they snored, if we thought they had sleep apnea, that's what they had. And things were exciting. They were exciting until 1996 when Cher published the paper that was a very, very major change in thinking on surgical treatment of sleep apnea. So in 1996, Cher published his famous paper where he looked at all the published data on uveal pharyngopalpoplasty, and basically his conclusion was that success rate was 40%. Everybody knows this paper, everybody knows the impact it had, and basically it killed a surgical treatment of sleep apnea because while certainly the sleep world, the non-surgeons considered 40% as a failure, and they would, for many years, they saw no role for surgical treatment of sleep apnea. And most otolaryngologists in those years also gave up. So, so there were many years that at the academy that we would come and we would find very little interest in surgical treatment. And that's during those years, 96 to the early 2000. And what we realized is, one, that UPPP was not for everybody, and two, that shortening the palate and taking out the tonsils was not enough. But one of the early works that I felt was important is, like, we know that UPPP does work. It doesn't work for everybody, but it does work. So all we need to do is identify the right candidate. If we can find the right candidate, then of course it's a procedure that might have good success. So that was the work that I borrowed from an anesthesiologist named Malampati. Malampati used a palate position to identify difficult intubation. So I modified that. And the big modification was Malampati has the patient stick out their tongue and then looks at the palate. So I modified it because when we want to assess sleep apnea, we don't stick out the tongue unless we're doing hypoglossal nerve stimulation therapy. So my position was done with the tongue in place, without the tongue sticking out. And also I realized that what we're really looking here is not really the palate position. Malampati called it the palate. We're looking at the tongue position is what we're really interested in. And everybody knows this, so I won't spend too much time on it, but it became obvious to me that there were favorable tongue positions, 1 and 2. When the patient opens their mouth, you see the whole uvula and tonsil pillars, or you can see at least the whole uvula and salpal, but not the tonsils, but they're all favorable. And these patients with big tonsils had stage 1 anatomic position, and these are the patients that are going to do well. Now, we also realized, I'm going to skip stage 2, and I'm going to go to the other extreme, that patients with a tongue position 3, where you only see the soft palate, or 4, where you only see hard palate, and if they have small tonsils and an unfavorable position, those are very, very poor candidates for classical uvulopalatoplasty, but they're also poor candidates for any surgery. And you'll see when we talk about it later, even in hypoglossal nerve stimulation therapy, we're not sure yet, but we suspect that these patients might be poor candidates even for that. So in between level 1 and 3 is level 2, which is a mix, either favorable tongue position, with small tonsils or unfavorable but big tonsils, and they're stage 2 and they're kind of in between, so they have some reasonable degree of success with palatal and pharyngeal surgery, but it has to be combined with some tongue-based surgery. And that's where the world of tongue-based surgery came into place. Now, I, like I think anybody else in our field, am a big believer that patients, by and large, with a BMI or greater than 40 are not candidates for upper airway surgery, whether it's any kind of pharyngeal surgery, tongue surgery, or hypoglossal nerve stimulation. BMI of 40 is a kiss of death, and they need bariatric surgery. Now, again, this is well known, so I won't spend much time, but anatomic stage 1 with UPPP, it's great, 80% success. Anatomic stage 3 has 8% success. So of course, this would be ludicrous to try and do surgery on a stage 3 with the classic UPPP. So what happened during those years? As the years went on, there were many, many modifications, many uvula sparing modifications, and we realized that we have to work on the lateral pharyngeal expansion. So there were lateral pharyngoplasty, there were modifications there, on the pharynx, on the palate, and then, of course, it became obvious that the tongue was a major problem, and tongue-based reduction procedures became popular. Genioglossus advancement, hyoid suspensions, all procedures to increase the retroglossal space. Of course, bimaxillary advancement has been around and is in a category by itself. So I'm not going to speak about it because it really isn't a category by itself. Overall, I would say in the United States, it is a rare procedure for many reasons. Even though the quota success rate is 90%, I see many patients who did undergo bimax advancement who still are coming in because of persistent complaints. One of the papers that Sagar worked with me on was the ZPP, which is a modified soft palate and pharynx procedure because it paid particular attention to increasing the lateral space in the pharynx. And the technique is also well known, with or without tonsils. It is a technique where we spare muscle, we spare all the tissues except for the mucosa. So the only thing removed are the tonsils and the mucosa of the soft palate. No muscles are taken out. The palatal pharyngeus is cut to bring it up laterally. The palate is split, and there is a lateral expansion, and both an anterior posterior expansion as well as lateral expansion. And this is an aggressive procedure that helped a lot of patients. However, like any aggressive procedure on the palate, it causes permanent changes in the swallowing. It is always a fine line between taking too much and having VPI, or taking too little and not solving the problem. Almost all of the patients have very mild subclinical velopharyngeal incompetence if they were successful. So it did help patients, and it still helps patients. It's not ideal. Everything we've done has helped patients, but they're less than perfect. One of my fellows, Dr. Lin, often known as Philip Lin from Taiwan, who is another superstar in the sleep world, and I'm sure you've heard from him. He's an outstanding speaker and published many peer-reviewed articles on sleep. But he did a meta-analysis looking at 2,000 patients almost, and multi-level surgery combining palate with tongue-based. He showed a success rate of 66%, which is far better than Scher's 40%. So that was a new era where we were combining tongue-based surgery with palatal surgery. And then to further advance this and to be a little more, I think, aggressive, robotic surgery came into place. Now, robotic surgery was exciting, and it still plays a role in sleep apnea. Now, this particular case I wanted to show was a ideal case for robotic glossectomy.
I think,
And this is a patient with significant lingual tonsil hypertrophy who's having a lingual tonsillectomy. So this is the epiglottis is down here out of the way. This is the lingual tonsils being released from the vallecula. And you can see there's quite a bit of lingual tonsil tissue here. Now the lingual tonsils are, we often don't think of it, but they're really separate. There's a left and right lingual tonsil. And they do have a cleft in the between the two. Now, in addition to lingual tonsillectomy, we were doing midline glossectomies and taking a variable amount of tissue from the tongue base. Also, patients that had epiglottic collapse, then the robot became a tool to remove the epiglottis in some cases. And then it became popular to do lingual tonsillectomy. So we wanted to study how often is lingual tonsil really an issue for sleep apnea. And we started studying it, and we didn't see it. We saw it very rarely. So we created a standardized lingual tonsil grading system. We published this. We looked at the inter-examiner agreement, which is very high, and we published this data showing the classification that I think everybody should use if they're publishing data on lingual tonsil removal. Well, we want to know, are they removing a grade 0? Are they removing grade 4? If they're showing results, we have to be talking the same language. So here's how we graded it. These are real photographs. This is a tongue base, which you rarely see. Now, this has no lymphoid tissue. So we graded this as a grade 0. And you see here the vessels, but no lingual tissue. It's like a bald tongue base. This is what it would look like. This is common, and it's a little bit of lymphoid tissue. So you see some lymphoid tissue, but not very much. And this is the artist's representation. But it's, now you can see, if you look at this, and this is grade 1, that removing this would unlikely help anything. This is grade 2, which is common, and it's still a little bit of thickness. I look at it like looking at adenoid tissue. When you have maybe 2 or 3 millimeters of adenoid tissue in the nasopharynx, taking out that is not likely to help your airway. And similarly with grade 2, I don't see much benefit in removing this much. Now, grade 3 has a significant amount, usually between 5 and 10 millimeters of thickness of lymphoid tissue. And grade 4 is almost never seen, but this is like the case that we showed with the robot, where there is a real significant lymphoid hypertrophy that tongue-based resection of the lingual tonsil tissue would be beneficial. So we started studying lingual tonsil tissue. We want to see, is it common and what does it look like? So we looked at 100 patients, and we looked at the distribution. And as you might guess, the distribution is lingual tonsil hypertrophy grade 1 and grade 2. Grade 4 is extremely rare. Grade 3 is rare. This is what most patients have. So you can see by the prevalence that it's not going to play a major role in treatment of sleep apnea. Now, we also wanted to look, is it common in sleep apnea? We thought, well, maybe all the patients with 4 would have sleep apnea. Now, the light gray are patients without sleep apnea, dark gray sleep apnea. And in every grade, we looked at the relationship, and they're equal. In other words, for grade 0, grade 1, grade 2, the patients with and without sleep apnea is about the same. So it doesn't look like lingual tonsil hypertrophy is a major factor in sleep apnea. Now, we're coming to, I guess, the point of this talk, which in my career started in 1995. So as I said, all these procedures are taking normal tissue. We're taking palate, tongue base, lingual tonsil, tissue, pharynx, whatever we're taking. These are really normal, healthy tissues. We are either cutting some of them out, we're realigning them, we're pulling them, we're stretching them. We are taking normal and making it abnormal, and we are trying to help the patient, but at the same time, under the best circumstances, patient has complaints. His throat feels different. He has some trouble swallowing. He has phlegm. He has postnasal drip. So we are helping the patient with some sequelae that we cannot avoid. So the idea of stimulating and keeping the tongue awake when the patient is asleep was very exciting. And Medtronic had a device that we were ready for clinical trials in 1995, which didn't go very far. There were problems in Europe when the initial, and Dr. Herman might have been involved in the early studies, and it never even made it to the United States, so we never started, or at least not in our center. And then it kind of disappeared for many years. What happened, Medtronic owned the intellectual property, and they didn't want to support it, but they didn't want to give it up. So it wasn't until many years later that the intellectual property was released, and many companies grabbed it and started the race to find a clinical solution. As everybody knows, Inspire won the race and got FDA approval 6 years ago. Before I jumped ship to Inspire, I was involved with Emthera, which is still a technique that's available, and I think it is approved in many countries, but not in the United States yet. So we'll talk a little bit about Inspire, since it received FDA approved approval in the United States, and it was approved with the following guidelines: moderate to severe sleep apnea. So AHI from 20 to 65. Currently, I think they even decreased it from 15 to 65, and less than 25% central apneas. Now, one of the key issues is all the studies were done with a BMI under 32, which probably is not a problem in India, but it is a big problem in the United States, since our typical patient here has a BMI of 40. So BMI of 32 is like winning the lottery. So it's many, many patients that want to Inspire do not qualify. And based on their initial studies, one of the exclusion criteria was complete concentric collapse at the level of the soft palate, which is not common but happens. And whether that's a true exclusion criteria is unknown, since once that was set up by the FDA as inclusion, nobody has really studied these patients to see if it would work. So the concept is simple, right? We know that when a patient's awake, there's no problem, right? We know that the problem occurs when the muscles relax and the tongue and soft palate come back, and there's obstruction. And of course, that's the whole process of sleep apnea. Now, what's interesting, and that was kind of a surprise to me, is that a stimulation of the tongue to bring the tongue forward also brings the palate forward. So Inspire therapy became a clinical option. And you're probably familiar with the idea It's a three-step process. The electrode on the hypoglossal nerve goes in, placed in the neck. The battery, the IPG, the pulse generator, and the brain of the whole system with the computer goes buried in the upper chest. And there's a sensor between the ribs that connects the inspiration to stimulation. The patient turns it on at night when he goes to sleep, and he can turn it off easily. Now, I want to show you both the palate and the soft and the base of tongue with and without stimulation. So this is the same patient, at the same time. This is what it looks like. This is what it looks like without stimulation. So this is a classical sleep apnea patient. They're having an apnea, they're obstructed. And now I'm going to show you the same patient with stimulation on. So as stimulation goes on, the airway opens up. And now I'll show you the base of tongue. Here's the tongue base, here's the epiglottis, and this is no stimulation. And that is the beauty of Inspire, that it is effective for tongue base obstruction at the level of the epiglottis. I was never a big fan of epiglottic surgery, although there's a lot of success with it and selected patients, but the idea of being able to correct epiglottic obstruction without cutting out the epiglottis is very, very, I think, soothing to me. I want to give a little plug for our second edition of our textbook, which has an excellent chapter written by Dr. Ryan Seuss on hypoglossal nerve stimulation therapy. It also includes almost, I think, every known surgical technique. We started this project, TK and I started it together, I think 10 or 11 years ago when the first edition came out. And then there were some changes for the second edition to update to include newer procedures. So we'll talk a little bit about Inspire hypoglossal nerve stimulation. And it's 3 incisions. One is between the hyoid and the mandible. That's where the electrode goes, and that's, of course, the key. The battery is in the upper chest, and the sensor is usually right above the 5th rib. Now, the anatomy, the key points that are important are this. The digastric muscle, everybody is familiar with the anatomy here. This is the anterior belly, posterior belly, digastric tendon that we pull down. The submandibular gland is pulled out of the way, up and back, and we identify the mylohyoid muscle. Once we have the mylohyoid muscle, then we retract the mylohyoid, and the hypoglossal nerve is evident. Now, this is a branch of the lingual vein. This is called the Renian vein. Many of us are aware of it when we do radical neck dissections and talk about it, but we've never encountered it like this. And it is just a troublemaker and annoying, and I hate it, but it's there, so we have to respect it. So in the surgery, it either has to be ligated or sometimes moved out of the way. Now, in Thera, hypoglossal nerve stimulation was a very, very easy procedure because the electrode goes around the main trunk. And Imthera had 6 electrodes. So even though the electrode went around the main trunk, there were different points of contact. So you can select whether you're going to stimulate a protruder of the tongue or a retractor. And the key is the hypoglossal nerve splits into branches. It goes branches that go to the genioglossus, which protrude, and glances that go to the hyoglossus, which retract the tongue. So, and the whole basis for this procedure is selective placement, so you're only causing stimulation of the genioglossus to protrude. If you have any of these fibers included, you can have a mixed result and not a good clinical result. So electrode goes only on the branches going through the genioglossus muscle. The second, well, placing the battery is a very simple procedure. That's not a problem for anybody. Placing the sensor is a little bit of a challenge for otolaryngologists because we're not used to working between the ribs. We're not used to the muscles here. So just for a quick anatomy lesson, the serratus muscles are on top, the line is attaching to the ribs. And once we separate the serratus muscle, we see the external intercostal muscles. And then there's another layer of internal. The sensor has to go between the external intercostals and the internal intercostals. So that takes a little bit of refresher course on anatomy. And here is the sensor being placed between the external intercostals and the internal. Now, many surgeons use a microscope. I personally do not, and I think that the technique can be done either way. The concept is pretty simple, that on inspiration, the sensor identifies that. It sends a message to the IPG, the center here, and then a stimulus is sent to the tongue. There are 3 incisions, one in the neck, one in the upper chest, and one just above the 5th rib. Now, what the difficult part of this procedure is separating the branches of the genioglossus, and that's what we're showing here. This is the genioglossus, and when we look at the stimulation, we can see 1, the tongue protrudes, and 2, if you look at the, this is the placement. So there's 2, in order to test this, we're placing 1 electrode, we're placing it, we're putting 1, this is the hyoglossus that was going to detect the hyoglossus, and this goes right below the mucosa on the lateral tongue. And this is going into the genioglossus, which is in the floor of the mouth. So it's just right off the midline lateral to avoid the Wharton's duct, and then it's placed in deep into the muscle. Now this is the here's the submandibular gland retracting. Now here is the mylohyoid retracted, submandibular gland retracted, the digastric is retracted, and this is the hypoglossal nerve, but this whole thing is the nerve. Now this is the genioglossus branch that we want. This is probably going to be the hyoglossus branch. These are the retractors. And this one is a beautiful picture, and this was done with a microscope, but you can see like the vasal nervosum, that see this little vessel here that kind of separates the 2 divisions. So there's multiple small branches here, and they call this the break point, separating the protractors from the retractors. So, and that's the key, is to separate these branches. Now this is that Renin vein, and here it is. It's either right next to the nerve or right on top of the nerve. And again, sometimes we can separate it and move it out of the way if we're lucky. You have to ligate it. And then once we once we identify the nerve, we do want to test it. We want to see if we're correct. In other words, again, we look at it, we think that this is the genioglossus and this is going to be hyoglossus. This is what's called a C1 branch, but we probably want to separate this. And these are all to be included. This C1 branch, genioglossus, and there's a transverse and cervical component here. And here, again, this is that's called the break point, and this is the branches that are retractors. So this will, if you stimulate this, you'll see the hyoglossus muscle moving. You can look at it. And here, if you look at the what happens when you stimulate, so this is the top is the genioglossus, and you only see genioglossus. You don't see any activity in the hyoglossus, which means there's no fibers here that are mixed in. And sometimes there's a tiny little branch that's mixed in that gives us a lot of trouble, tortures us finding that little branch. But here is pure stimulation of the genioglossus, and you have a flat signal in the hyoglossus, which is perfect, which means that we have no branches mixed in. And then we'll also be testing the hyoglossus branches. These are the retractors. Now look, when we stimulate here, the lower, you have stimulation activity in the hyoglossus, but no activity in the genioglossus. So once we've had this separated, then we put the electrode around it. And that is a challenge sometimes because we don't have a lot of space, but once the electrode goes around, this is the hard part of the procedure. And it really is a two-man procedure. So Dr. Venkatesan and I work together. And now this is the sensor placement, which this is now looking at the area. Now here is the intercostals that has a very classic appearance once the serratus is separated. And you can see the different areas. Now this is the external intercostals, this is the anterior serratus, and then this goes between the external and internal. Here's the sensor being placed in. Now once everything is set, we want to test the system, and we want to see the tongue come straight out. We do not want to see the tongue going up because that happens sometimes, which means we have to go back to our nerve and identify any kind of retractor branches that we included. Now we also want to test to make sure that our sensor is in good place, which we can see on the graph. Now, just to point out again, there are the nerve breaks into multiple branches. The area that separates them is identified as a break point. Genioglossus branches are protruders, and the hyoglossus branches are retractors. So the electrode has to go on these branches. I think we're. So what are the potential risk? There can be some hypoglossal weakness, and usually it's temporary. They have no reported case of permanent. People complain of discomfort. Infection is pretty rare. There's a lot of complaints, but most of them are temporary. The big problem is that we could make almost every tongue come out enough to correct their sleep apnea, but if that protrusion wakes them up, then we've accomplished nothing. So it's the fine line between having protrusion that does not wake them up and still enough protrusion to correct the problem. So that's why it doesn't work for everybody. And every patient is different on what they can tolerate in terms of the tongue protruding. There are potential problems, neuropraxia of the hypoglossal nerve. As I said, it's usually temporary. One of, I think, is a major concern is marginal mandibular nerve weakness. The marginal is right there when you're making the incision. So if you don't take the time to identify it, they're going to get some marginal weakness, which is a problem. There are, of course, other potential risks with it. What's the success rate? Well, there was one systematic review, meta-analysis published, just looking at 350 patients, which is not very much. These are published patients. There's over 6,000 patients implanted, but the success rates in the published papers goes anywhere from 55% to 100%. Now, well, you always wonder when somebody publishes 100% success, but probably the mean, which is 70% success, is very real. So one of the things that we looked at is, okay, we had the same thinking that we thought about U2OP. Well, 30% of the patients fail. Well, maybe we can identify who fails. So we looked at some kind of common ideas. We know that we think when the patient opens their mouth, their airway decreases. We know that we think a mouth open causes a diminished airway. That's why nasal obstruction, mouth breathing can be an adverse effect for sleep apnea. And we looked at this and studied hundreds of patients and took photographs and measurements, and it's true. When the mouth is closed, the airway space is bigger when the mouth is open in 67% of the patients. But it's not true on every patient. There's 33%, a third of the patients, where their airway actually is bigger when their mouth is open. So we found that interesting. What about the tongue coming out? We also know, well, we think, well, if the tongue protrudes, it's going to improve the airway. And we studied that, and we found that that's true again in the majority of patients. Tongue protrusion improves the airway, but that's not always true. So there are patients, a smaller percentage, but a significant percentage, when the tongue protrudes, the airway diminishes. And maybe these patients should be assessed, and maybe they're poor candidates for hypoglossal nerve stimulation. And that's what we're studying now. We don't have an answer, but we think that might be a factor to improve success rates. The key points in this study is the study confirms longstanding accepted recognition that mouth opening reduces the airway and tongue protrusions enlarges the airway in most patients. However, it's not true in all patients. A third of the population responds atypically. Now, before I close, I want to talk about the future. Now, this may or may not be the future, but the next step in clinical trials in this country, which has already been started in Europe, is bilateral stimulation for sleep apnea. And this is called, this technique is the NIOX technique, which I think the company is NIOX, but there are two main differences between this and the classical technique. Now, this is not a great photograph, but let me just show you. I started with Imthera. Imthera put the electrode on the main trunk of the hypoglossal nerve. Very easy to do. And then there were different, the cuff had 6 electrodes, so you can select what side of the nerve you want to stimulate. Inspire puts it only on the protractors, so we have to separate the fibers, and these are the fibers going to hypoglossus. Now, this system goes way far out, So we're not even close to the retractors, and we're at the distal branches going to the genioglossus muscle. Now, so what it does is, here's the genioglossus muscle, and these are the fibers. And since they're small branches, it doesn't put a cuff around the nerve. It puts like a paddle on top of the nerve to stimulate it. So that's one of the major differences. The second major difference is that there's no implanted battery. There's no power source implanted. The power source on this system is attached every night externally. It's just a pad that goes on from the outside. Now, the biggest, I think, detractor from the appeal of Inspire is people are concerned about having something implanted in their chest. The battery pack is a concern for many people. So this is an exciting idea where there is no battery implanted. And two, the idea that it's on the distal branches is exciting. Of course, it's early and we have no idea if it's really going to work. It's there for us to study in the future. Now, at the last Academy, I took a position, as we had a discussion pro and con hypoglossal nerve stimulation. So I took the position of con. And then when I took it, did I really mean it? Well, not really, because I'm a big fan of it, because I like it because it's not destructive. I'm not cutting out tongue. The complication rate is much less than dealing with pharyngeal surgery, tongue-based surgery, palatal surgery. There's no bleeding. There's no severe pain. They're not in the hospital. They go home the same day. So I'm a big fan of it. But on the other hand, we don't know exactly who the best candidate. We need long-term studies. So it's not perfect. From a patient's perspective, not everybody wants it. They don't want the implant. They're worried about going to the airport. They don't like the idea that something that looks like a pacemaker. The battery life is 11 years, but they're worried about it. And they don't like the external incisions. Marginal mandibular branch injury can happen. It's a problem. It's not appropriate for patients that have insomnia plus sleep apnea. And then cost, insurance coverage. These are issues, although in the United States, they're becoming less and less of an issue, and it's often covered by our insurance. But throughout the world, the cost is a big issue. These are expensive systems. In the United States, I believe what the hospital pays for the system, just that their hospital payment is $35,000. And I just wanted to review one thing. When we started UPPP, we were very excited, but by many years later, the success rate was 80, was down to 40, and the new studies are still showing success rate of all the modified palatal procedures. Success rate is still around 40 or 45%. What about TORS? Well, we were excited about robotic tongue-based surgery. 66% we reported initially, but 4 years later, this is a meta-analysis systematic review showing 47%. So it's not going in the right direction. So the STAR trial showed 80% success for Inspire. Later studies by Woodson showed 63% success, but okay, where are we going to be in 10 years? Well, we don't know that answer. So all of us, I think, get excited about new procedures, but do we know the final answers? No. So what do we need to study? Can we do anything for patients with a BMI that's a little higher? What about concentric collapse? Is it really a contraindication? And we're very interested in those patients that show decreased airway on tongue protrusion. We need to look at long-term results, and maybe AHI is not the only factor we should be looking at, which is a topic for discussion with any surgery. So I want to close with the myth of the pot at the end of the rainbow. I guess the Irish version is that there is a pot of gold, but the leprechauns hid it and they buried it. But I would think that my one thought, if you ask me, where's the pot of the gold at the end of this rainbow and sleep apnea, then I hate to say it, but for right now, that pot is still Cpap. So the longer that I involved in sleep apnea surgery, the bigger the fan I am of Cpap. And I clearly only recommend surgery for those patients who absolutely cannot use Cpap or will not use Cpap. And I guess we'll leave questions for later, unless you want to take questions now.
Thank you very much, Professor Friedman. I will take the question at the last. It was a wonderful talk. I would request Professor Carl Homan to deliver his next talk on multi-level assessment and management of sleep disordered breathing. Professor Carl Homan is a senior consultant ENT surgeon from Mannheim, Germany. He had fellowship in plastic surgery and became a consultant at the University Hospital Hamburg, Germany. And he was honored presenter of the Eugene Maynes International Lecture at San Francisco, USA. And he is the visiting professor of the Royal Society of Medicine, London, UK. And he served as the president of the Union of European Medical Specialists Oral Section and Board, and also the German Society of Oral and German Academy of Oral HNS. He is also the president of German Society for Endoscopy and Imaging, European Academy of Oral, and World Congress of Bronchoesophageology. He is also served as the German Society of Sleep Research and Sleep Medicine and is the honorary president of German Society. He has special interest in the surgical and non-surgical treatment of sleep-related breathing disorder. With his extensive experience in variety of advanced sleep surgeries, I would request him to take over and share his view on surgical management of OSAS. Over to Professor Carl Homan.
So, thank you very much, and to everybody, and thank you very much for the wonderful talk of Michael Friedman. I hope I can add a little bit or just give another view to the same topic as.
Point 8 and make a big jump.
This is wrong. I have to go back. So, first of all, thanks to Dr. Krishnan for this perfect organization, and we so now, and it should work. So so as Dr. Krishnan said, I'm currently president of the European Academy of Sleep Medicine, and also a little bit involved in the International Advisory Board of the American Academy as chair-elect. And we are all really sorry that due to the Corona event, we cannot meet physically, but we can see that this is a way how we can share our opinions, and this is very important. Can you hear me? Everything fine? This is the classification of sleep disordered breathing. There is without obstruction and with obstruction, and it's essential that we as surgeons focus on the sleep disorder breathing with obstruction, and because our competitors, or let's say co-workers, or in the field of sleep, the pulmonologists and the neurologists and all the other ones, when I started in this business in 1990 or something like that, they called me a butcher, because they were very, very convinced that any kind of surgery in an obstructive sleep apnea patient is butchery. And so we have to, as Michael Friedman also mentioned, we have to identify the best candidate for our surgery. And that's one of the topics of my talk. So very important for us as ENT surgeons is that we have to have a document about the case we do before surgery. And a fully attended polysomnography is not only very expensive, it is a long waiting list and so on. And according to the International Code of Sleep Disorders number 3, the out-of-center testing, just to like a wearable now, is equally good to exclude a non-surgical disease. So there are screening apps, and this is a comparison. I go with my pointer here about the AHI, which was found in polysomnography compared to a smartphone RDI, and you see it is almost the same. And this, I hope it will work, gives you an insight in the problem we have also in our pediatric population. This video was brought to me by the parents, and you see the child has first of all the mouth open. You see the retractions of the chest and of the abdomen, and the child is really fighting for its life. So, and if the oxygen level comes down enough, you will see that we have this arousal, and this arousal gives the brain the information: be careful, you are about to die. And then you see also the movement of the arm. It is not only a dangerous problem, it is life-threatening. And it reminds me very much to my, at that time, 3-year-old son. I performed, he was 3 years like this child. I performed a T&A in his case, and he's now 26 in the doctor, and everything was fine. So there are really cases where the surgeon has not only the knife in the hand, he has also the solution for the problem. And this depends what you want to do. For example, stiffening of the pharyngeal wall, active opening of the airway, increasing muscle tone, removal of anatomical structures, we can achieve surgically. But as Michael just said at the end of his lecture, the increase of interluminal pressure can only achieve by Cpap. And very important, again, the proper diagnostic. This is a fully attended polysomnography, but with the progress of our IT possibilities, that we have not only the Zoom meeting together, but I can look at my wearable and can tell you how many sleep stages I had last night, what my heart rate is, and my ECG. And this will be the future, especially for us as surgeons. This is just a report, as you're all familiar with, the different sleep stages, the REM phases, the different positions, supine, right, left, and the variation of the heart rate. And you can see why the heart rate is so variable there, because the oxygen level drops down on here for a half an hour on 70%, which is caused by the hypopnea you have here, and the acoustic background is the snoring, and here the incredible amount of arousals, and here also, which is very, very important. Therefore, in a fully attended polysomnography, you also wire leads to the legs, is the periodic leg movement disorder. And again, back to the last slide of Michael Friedman, if the patient is able to use a Cpap mask, everything is fine. You have almost 100% oxygen level, no periodic leg gloom, no snoring, nothing, everything. And that is our challenge as surgeons. There are fortunately multiple modality treatment concepts, because sleep disordered breathing is characterized by multiple pathogenic factors. For example, age, weight, anatomical obstructions. And conservative options are not only nasal ventilation therapy, but also oral devices, vests preventing the supine position, weight reduction, nasal dilators. You will ask me, why do you tell me these stories as a surgeon? You are a surgeon, I am a surgeon, but when I was called a butcher in Germany some 30 years ago, I qualified as a head of department at that time in sleep medicine and joined the party. I established my own sleep lab, and we have up to now 20 patients every night in my sleep lab, and we prescribe the patients 2,000 Cpap masks a year, and so on, all these things. The situation in our country is maybe a little bit different to the United States and to UK, but maybe comparable to India, because you can offer the patient all choice in sleep medicine. You as surgeon, you do not need only the knife, you can also change to different choices. So the gold standard is the Cpap mask, established 1982 by Colin Sullivan, and we all know that, especially in the time of telemedicine, you can look into the device also if the patient is in Brisbane on the other side of the world, and you can also change the setting if needed. So the acceptance of the machine will be hopefully better in the future. We all know how it works. You see here the obstruction and then the mask on the nose. It works like a reversible vacuum cleaner. And some of my patients say it is not so sexy to sleep with a mask off the nose. I have to explain them that they have not to wear the mask while they do sex, but afterwards it is maybe a little bit more peaceful in the sleeping room. And the compliance of the mask is really about 50%. So that's the gap where we as surgeons can jump in, as also Michael said in his lecture before. One of the choices I do very, very successfully is an oral device. I provide them, okay, my own daughter is an orthodontist, but this can also do an ENT surgeon. This is a thermolabile plastic. You heat it up to 100 degrees Celsius. Then the patient bites on it, protrudes his lower jaw forward, if he can do that. And you see that if you compare the yellow arrow here to here, because his mandible, his lower jaw was protruded about 1 centimeter, he gained 1 centimeter here. If this guy has his own teeth, no temporal mandibular joint problem, and he has a protrusion, it is an option to help him if he cannot accept the machine. And is not open to accept any kind of surgery. Here, this is a positional obstructive sleep apnea syndrome, a serious problem. Everybody knows the sleep partner turns on the backside and starts snoring because due to the relaxation of the muscles, the tongue base folds back, obstructs the upper airway, and then the oxygen level due to this airway blockage drops and the CO2 increases. And this positional OSAS is defined as the AHI in supine is greater than twice the AHI in non-supine position. What is very important for you as a surgeon, 66% of patients become position dependent after multi-level surgery. What is the reason? If you remove tissue from the upper airway, like tonsils, parts of the soft palate, and so on, there is space enough for the tongue base to fall back and obstruct the upper airway. So it is wise for you as a surgeon, if you make an informal consent, that you raise this problem if you want, and inform the patient that there are options. For example, this commercially available vest preventing the supine position, or this sleep positioning trainer of Nico de Vries, and or much cheaper, the smartphone app, the Apnea app. This is, you can buy it in Google Play Store, or if you have an iOS, you can buy it here. And the results are, if you have a positional OSAS, are very promising. Look here, this is a study of my co-workers from 2017. You see that the time spent in supine position dropped significantly, almost to 0, using these apps. And also the AHI came down to below 10, and then there is no need to treat the patient anymore. So we have options, ladies and gentlemen. And in conclusion, after 6 months' time, smartphone app, 70% usage, night balance, 74%, and the West only 30%, and the MAD 77%. The definition, according to Van Manen, is more than 4 hours per night and 5 days per week. This is very important. We come on that later if we compare the success rate of CPAP to surgery. So, in conclusion, these tools are promising, but in general, you all know that the medical apps in general are not validated sufficiently, and there are no approvals by medical authorities, at least in Europe, and the ongoing support is not secured. The best option is to reduce the body weight. Unfortunately, the success rate is only 3% on the long run. And as Michael said in his lecture, that I think 1/3 of the American population has a BMI of more than 35 or something like that. And all over the world, the number is increasing. And I make a written consent as a surgeon with the patient in the presence of a witness, a resident or something like that. And both have to sign that the success of any kind of surgery in sleep apnea depends on a BMI of 25. Because we all know OSAS depends on gender, age, alcohol, and body weight. Okay, you will age continuously every day. You will not change your gender, quit alcohol, but the big problem is the body weight. And if this guy comes back 2 years later to tell you everything was fine, but now I am snoring again and I have my apnea, then you take out your paper and show him what is your body weight now. And then he is in a not so happy situation, and he cannot sue you. this is rubbish. All this nose and breathe right or so does not really help you to against sleep disorder breathing. But back to the surgical options, which increase muscle tone, active opening of the airway, stiffening of the pharyngeal wall, removal of anatomical obstructions. We have 3 levels: the nose, turbinates, sinuses, soft palate, tongue base, and the hyatt and larynx. And if you have a septal deviation like that, a hypertrophic turbinate, or this polyposis nausea syndrome, do it. Make the septoplasty, do the turbinates, make the sinuses, because the success rate in simple snoring is about 40%, and also it is improving OSAS. In my personal opinion, and also if you look in the literature, the indications for nasal surgery for sleep-related breathing disorders is subjective impairment of nasal breathing to optimize nasal ventilation therapy. And then we are with this tonsils, kissing tonsils, webbing, soft palate, and the slack is correct in English, uvula. If you have it, do it, because you can only help the patient in his sleep-related breathing disorder. This is a study of one of my co-workers, the co-author of our book about surgery for sleep disorder breathing, Thomas Ferse. These are individual cases. This is AI or AHI before, and this is after tonsillectomy, simple tonsillectomy in adults. Only tonsillectomy, no other procedure. And you see that in the mean, in this 32 patients, the AHI dropped from 44 to 6.8. So if the patient opens his mouth and he has giant tonsils, shake his hand, say, you're a candidate, have a good day, make an appointment, we remove it. And I do not want to repeat Michael's view to the history of the soft palate surgery, but again, Fujita, Powell, and you will ask me, why do you think that, oh, sorry, Beck, do you think that this uvula flap, as you described in 2001, has any difference to U-triple-P or something like that? The reason for me was that my patients after U-triple surgery came back, let's say 6 months later, and said, doctor, I don't snore anymore, and I have almost no apneas, but I have this foreign body sensation in my throat. I have always to cough. So like we know it from laryngopharyngeal reflux. And so I had the idea to flap this uvula forward. And so we preserve the here the mucous membrane from the uvula and suture it in front of it, like here. And you will not believe it, but it really reduced the complaint of the patient, because if you swallow now, just listening to me or watching me, then you will feel, you won't feel your soft palate. But if you have a scar at your soft palate, it diminishes the humidification of the throat and makes this foreign sensation. And the uvula flap is really an advantage for the patient. Combined classical radiofrequency surgery is an outpatient procedure. You can do it in a local, and it is really a good, promising tool. We have here a baseline in a visual analog scale only addressing snoring, and after session 1 and session 2 it reduces. And the wonderful thing with radio frequency is you can repeat it. You can do it once again. In the informal consent, I inform the patient that he also has to go to the hairdresser because his hair grow, and so maybe sometimes he has to come back to me to do again a radio frequency to make the tissue stiff again. Go ahead. The pillar implant system, Michael spoke about that. It is really no success, and you just have, if somebody speaks about that, congratulations, but in Germany the patient refuses it, it's too expensive, and the risk for gagging and extrusion is too high. The radio frequency of the soft pellet, especially if you only do it for snoring, is safe and effective, and sometimes also effective in obstructive sleep apnea syndrome. The radio frequency of the tongue base, in my experience, especially if you keep in mind my story about the position of obstructive sleep apnea syndrome and the challenge of a TORS, of a robotic surgery of the tongue base, it can be, let's say, a minimal invasive approach to reduce the volume of the tongue base without any risk to nerves or after bleeding or so, also as an outpatient procedure. Higher suspension, as I do it, we use only a wire, the same wire that the thoracic surgeon uses to close the chest. We go with the needle through the thyroid. It could be a problem if it is ossified, but then you can use a burr to make a hole and come back behind the hyoid, and then we close the gap between hyoid and thyroid via the knot and bring the hyoid in front of the thyroid. And it's essentials in my experience to preserve the stylohyoid ligament. Yeah, I know that Powell and Riley, they cut it, but we want to preserve it because this ligament holds all the posterior airway space open, like the Cpap machines blows it up, so we don't cut it. And this brings us to the really very important point of combination of different surgical procedures, the multi-level surgery. You know, if you have a nasal Cpap, the nasal Cpap blows up everything from the nose to the throat to the entrance of the lungs. And if we want as successful as the Cpap mask, we have to address all these levels. And one of the ways is this kind of multi-level surgery, the uvula flap combined with the radio frequency of the tongue base and the hyoid suspension. And you can see here this really bulky tongue base and the whitish lesion here. This is the lesion after radio frequency the next day. So if you do the same MRI 3 months later, the whitish lesion is vanished and you have a scar here. And everything is held in this position via hyoid position for suspension. So the results of this is multi-level surgery. You can see 57.6% and the acceptance of a Cpap mask, not our studies, different studies, see about 60%. But ladies and gentlemen, that's the point if we discuss with other sleep doctors. If you do any kind of surgery, the patient has the result of the surgery for 365 nights or days a year, always when he falls asleep. But the Cpap mask is only effectful if the patient uses the machine. And unfortunately, they don't use the machine every night and every hour in sleep. I can tell you because the memory stick of the Cpap mask document very precisely how many hours the patient uses the device. And since we have every night 20 patients in our Cpap Mask and a lot of in our sleep lab and a lot of other patients in our office hours, we definitively know that unfortunately a lot of them, they come very, very happy with their machine, but unfortunately they don't use it every night and every day. But after sleep surgery, they have it 100% all their life. And this is just an image. On the left side, a CPAP failure, 40 per hour. And after the modified high suspension radio frequency of the tongue base, and you can easily see the difference that the epiglottis on this side is more retracted. Go back, yeah? So, and we asked our patients quite early, 15 years ago, about the result of this multi-level surgery, and 94% reported no snoring anymore, and 84% would undergo the same procedure again. But everything depends on body weight and severity of disease. You can see on the left side that a low BMI and a low AHI are the best situation for any kind of surgery. So higher the BMI and so higher the AHI, so worse the surgical outcome. And I think for this case is only bariatric surgery is a successful sleep surgery. So I just come also on active implants because we do about 100, and as Michael, thank you for mentioning this. Before in the 90s, we had the tickets to Minneapolis for the studies and so on. And then, as you said, the development was canceled, but now it is really very successful. And in Germany, these devices are covered or reimbursed by the insurance companies if the indication is given and if you request or ask the insurance company in advance. And very important, as he said, is that you find the branches of the nerve which protrude the hypoglossal, the tongue, because the tongue is the most movable muscle in your body. While you listening me, please move your tongue, press your tongue to your hard palate. Right, left, you can swallow, you can stick it out, you can do everything with it, but you have to have the right branches, otherwise you stimulate an obstruction, and that's not the idea behind the device. So we heard there are two different devices, and at least this is the Inspire, single-sided right-side pressure sensor, 3 incisions, and synchronized with respiration. And this is Imthera, and you see the colored areas of the nerve. They are alternating, stimulating the nerve. The reason behind is to avoid that the nerve gets tired and cannot move anymore. And the big advantage, we have only two incisions, and the battery is rechargeable, and it is non-synchronized with respiration. So that should work. Sorry, again. Yeah, no, so this is in the theater.
Brustkorb und so weiter rumdrücken. Very strong.
Yeah, maybe. Oh yeah, it was 0.8. I make a big jump.
But even pushes.
Now look at this. Oh, sorry. Oh, sorry. This is again. I tried again.
So. So mal nicht auf den Brustkorb und so weiter rumdrücken. Very strong.
Yeah, maybe. Oh yeah, it was 0.8. I make a big jump.
But even pushes.
You will not sleep with a stimulation like that. That's why we know now it works. And 4 weeks later, when the wound healing is finished, we adjust the stimulation to the individual patient. This is the paper from Lancet, which made the FDA approval possible. And these are the figures after 1 year, 68% reduction of AHI and sustainable response also after some years. And also after 4 years, 80% of the operated patients use the device. And if you withdraw, just stop the computer, everything comes back as it was before and you have to start it again. It's the proof that the effect comes from the selective stimulation. So open question, synchronization with respiration necessary, predictors of success, bilateral stimulation, automatic titration, position sleep stage, and long-term effects like draining, no effect after withdrawal of more than 1 day. Fatigue, no, not visible clinically after 48 months. Hypertrophy could be a hypertrophy of the tongue, not visible clinically after 48 months. Cardiovascular risk reduced and vigilance and accidents increased, not accidents. This is Nyxoah, as Michael also said. We have done here in Mannheim this year 5 of this, because the device has now a CE approval, not an FDA, but a European approval, so we can implant it. And the nice thing is you have only 1 incision, as you can see, 4 centimeters long between mandible and hyoid bone, and not 3 or 2 incisions. And everything, the software and the battery is in this disposable dispatch outside. This is, you can every day change the situation and the setting also. And the nice thing is what you can see on the right slide, there is also an opening of the soap pellet observed. And you can combine this technique with apps, with tonsillectomy, with UPPP. You can combine everything because you're a surgeon, and you can also use this oral device, and you can use oral device after multi-level surgery, like here. We had here, we had here first in 97, the septoplasty and tonsillectomy. It reduced the AHI from 51 to 30, and but it was not successful. And with the oral device, which is called in this case Snorban, it dropped to 4.4, and 2 years later, without Snorban, same result, 30. So widening definition of OSAS news. Diagnosis allowed with out-of-center testing. Smartphone apps could be like wearables in general, the tools for the future. Passive tongue implants, really, I do not know, under investigation. Active, fantastic. And very important for us as a surgeon, combined therapy of surgery and other treatment or modalities is beneficial for patients. So changing habits is very important. If you want to join the European Academy, you're welcome. And this is the first edition. Now the 3rd edition of this book is in press. I thank you for attention and best regards to the moderator in India. Thank you very much.
Thank you very much, Professor Kaumann. It was indeed a wonderful presentation. Before going for the discussion, I would like to announce the demise of our pioneer in the field of sleep medicine, William C. Dement, who passed away this week, June 17, who is known as the father of sleep medicine, who was a leading authority in the field and is a key force in founding the American Academy of Sleep Medicine and the Sleep Research Center at Stanford University. So I would like to request to be in silence for a few seconds to pray for his soul to rest in peace. Thank you. So we have a lot of questions. So first I would ask Professor Friedman, are you still doing zeta paltopharyngoplasty? If yes, in which situation?
Which plastic?
Z palatoplasty.
Your question is, are we still doing Z palatoplasty?
Yeah.
The answer is very rarely. So I have to admit that my go-to procedure now is hypoglossal nerve stimulation therapy.
Okay.
So there are few situations where I would want to go directly to a pharyngeal surgical resection. I think one of these situations might be, I recently reviewed a paper where they showed that patients with complete concentric collapse can be converted with oropharyngeal surgery. So there might be an indication if the patient is not a candidate for hypoglossal nerve stimulation. And I'm sure there are isolated cases, I think. Obviously, patients with Friedman tongue position and anatomic position 1 are candidates for classic UPPP. In some cases, when there's a long, soft palate or modified, we use a lateral pharyngoplasty as our standard. When I was, I think 2 years ago, maybe at the Academy, I took a poll. I said, how many people consider the Fujita uvulo-pharyngopalmoplasty as still a standard? And I think the answer was very few. I think that the uvula preservation techniques, the lateral pharyngoplasty, have pretty much replaced what we call standard uvulo-pharyngopalmoplasty. So again, anatomic stage 1 or even sometimes 2, big tonsils. Certain cases, evidence is clear, like Professor Herman talked about. Tonsillectomy sometimes is an answer. There's a lot of evidence that that's true. Modified uvulo-pharyngopalmoplasty with a lateral pharyngoplasty is I think a good procedure. Big tonsils, good anatomic position. But once we get beyond that, if we're talking about aggressive procedures that require Z palmoplasty or glossectomy, almost all our patients are going to hypoglossal nerve stimulation therapy. So it's been a while since we did aggressive palatal and tongue-based procedures.
We always hear a lot about zeta paltoplasty from your disciple, Dr. Vidyasagar. Can you hear my voice?
Can you repeat the question?
Yeah, we always used to hear about zeta paltopharyngoplasty from Dr. Vidyasagar. This time we would like to ask you a couple of questions on that. Especially, we always feel that zeta paltopharyngoplasty is an aggressive procedure and can cause velopharyngeal insufficiency. So if it happens, if there is a overdue and if there is a severe velopharyngeal insufficiency following surgery, so how to manage?
So the question is how to manage velopharyngeal incompetence, insufficiency after an aggressive palatal pharyngeal procedure, especially ZPP, which is aggressive procedure, which I always reserve for severe cases. I would never do it for mild, moderate. I am not a fan of resection for snoring or for mild sleep apnea. For snoring in mild cases, I'm a big fan of minimal procedures like Professor Herman talked about, if it's mild snoring. And typically, in our patients, mild sleep apnea is concerned primarily because of snoring. It's a social issue. It's disturbing the bed partner. And that's why most of our patients come in. It's very different if the patient comes in because they're tired. Patients that are tired are very different than patients that only complain of snoring. So if the same AHI, if you're looking at an AHI of 10, if they're complaining of snoring, it's one situation. If they're tired or they have other symptoms, high blood pressure, it's very different, much harder to make those patients clinically improve than the patient who's snoring. So the patient who just has mild sleep apnea snoring, then I'm a big fan of nasal procedures, including nasal valve repair. I think that the nasal valve is frequently overlooked in sleep apnea. I think after septoplasty and turbinate reduction, these patients with sleep apnea or snoring have a higher incidence of valve collapse. And therefore, like Professor Herman showed, nasal cones and breathe right strips are beneficial. If they are, I do a definitive valve repair. And the technique I use involves a Mitec soft tissue anchor, and I've published it before. I'm not a big fan of Latera, which is a popular new shortcut. I personally have not had good success with it, although others have. So the question comes back as you have a patient with severe sleep apnea, they have unfavorable tongue position, tonsils are not huge, and they're for one reason or another are candidate for ZPP. Well, we did many ZPPs over the years, and each one is a borderline VPI. Each one has temporary VPI. If they don't have temporary velopharyngeal incompetence after surgery, then we're worried that it's not going to work. The amount of space behind the palate is huge, but 95%, 96% of the time, it's temporary. 1 month, 2 months, 3 months, it goes away. I have at least one patient I know that it was permanent, and we did work with a prosthodontist to create a soft palate obturator that solved the problem, but it's not a pleasant complication to deal with, and there are no good surgical corrective measures. So it's rare, but it can happen, and it's one of the reasons why, when possible, I will now choose hypoglossal nerve therapy, and why I go back to my final comment about CPAP, that we should never forget CPAP. And the patients that will not use CPAP, they really have to be committed to accept the risks of surgery.
Thank you. One more question from Dr. Vidyasagar Dumpala from Hyderabad. What are the other procedures and your opinion on barb pharyngoplasty?
So,
your opinion
repeat
on
it one more time. Could you repeat the
opinion
question?
on barb pharyngoplasty?
Barb suture pharyngoplasty.
Which pharyngoplasty? Which one?
Barb
Barb.
suture.
We're missing the sound. Our sound quality.
It's barb sutures. Barb.
Oh, Barb. Oh, Barb. Okay, so the system of using barb suture. So I have to admit that I'm an accomplice to one of the papers that was written, and I was involved in clinical studies of a technique with barbed suture for snoring. The way the study was conducted, we did get some improvement in snoring. And the beauty of the technique is that it's so simple. There's no risk. There's no long-term side effects. However, I am not happy with any of the currently available systems that I feel that they're good enough to work. I mean, I think the cost-benefit ratio is just not there. So right now I do not use it. Same with the pillar procedure. Pillar procedure does work, limited patients. The problem is they have to be a good anatomic position. You can't take a patient with a tongue position 3 or 4 and do a pillar. You can't take a patient with a BMI of 40 and do a pillar. And you can't take a patient with big tonsils. So if you have a patient that's thin or relatively thin, and no tonsils and a nice tongue position, well, most of them don't snore, but occasionally they do. And in some cases, the pillar procedure is helpful, especially combined with nasal procedures. Like Professor Herman said, nasal surgery alone is effective about a third, 40% of the time in snoring, if we're dealing with snoring. But if you add some palatal stiffening, I think the combination is very helpful. I think one of the reasons we do less pillar procedures in this country is that it's not covered by insurance. It's relatively expensive, but I still prefer it because, again, very low risk. If it works, it's great. If it doesn't work, you really haven't produced any great problems.
Okay. Professor Michael Kahali from Brazil to Professor Carl Homan. So how do you measure the snoring level in order to report success in primary snoring?
Oh, that's a very good question. In general, we have a visual analog scale, and most of our patients are male. So the lady makes the cross, and you know, there is mostly a fight between the couple about the amount of snoring, but it is documented, signed by both the bed partner and the spouse and the patient on a visual analog scale how loud it is.
Thank you. And Eva from Poland.
Ah, Eva, hello.
Yeah, to Professor Homan. If we have a patient with complication you mentioned during your presentation, such as pharyngeal sensation and cough after pharyngoplasty, what would you recommend to do with the patient?
To be honest, it's a kind of psychiatric advice. I tell him that what he suffers from is related to that's honest between doctors now, amongst us. I tell him that the pH in his throat has changed because of the surgery. So he has to take a PPI, high dose, 40 mg in the morning and 40 mg in the evening, and to drink at least 3 liters a day to make the posterior airway space humid, and this definitively helps. But it is better to avoid it surgically. I agree.
And Eva,
from the uvula sparing procedures, we have a little bit less than we used to have with the classic uvulopalatoplasty. But I guess it's the price they pay for having surgery to correct their life-threatening disease of sleep apnea.
Yeah, you're right.
Dr. Eva has one more question to Professor Friedman. I always learn so much from you, and we have not started hypoglossal nerve stimulation program. So need to stick with different types of pharyngoplasties, tongue-based surgery, etc. Based on your huge experience in sleep surgery, what can help us to make sure that during pharyngoplasties or tongue-based procedures, we obtain enough muscle tone to have ventilatory stability, and whether we were able to tighten the whole length of the airway. So, to Professor Friedman.
So I think the,
Can I
I'm
repeat?
not sure I heard the question, but I think the question is, how do we choose which technique? Is I think one of the, well, I'm not sure that was the question, but that's the question that I get asked all the time, especially when we do our panels with many experts. We will hear 6 different palatal-pharyngeal techniques, each one showing his technique and showing results. Palatal shortening, the Woodson technique, lateral pharyngoplasty, Kenny Pang. We have a Kahali procedure that's more aggressive. We have the ZPP, and we have modifications beyond that. So my answer is that in many, many situations, the result is going to be the same. There is not one technique that's specifically appropriate for one patient. Obviously, the decision has to be made. What are we addressing? Palate, is it too long? Is there an anterior-posterior problem? Is there a lateral collapse? Do we want to widen the pharynx? And do we need to do something with the tongue base? So once we address which areas we're going to work on, I think that each surgeon should have one technique that he's comfortable with or she's comfortable with, and then they could achieve results. I'm not sure that I don't think each surgeon needs 10 different oropharyngeal techniques in his bag for him to use, like thiohyoid suspension, tongue base. Do we use a robot? Do we use a coblation? Do we use a radio frequency to reduce? All those things may end up with the same result, depends how aggressive. Now, I'm concerned about very aggressive tongue-based reduction. So as the ability to remove midline tissue from the tongue base improves, whether you're using radio frequency, and Dr. Lin in Taiwan has amazing videos showing how he reduces a huge segment of the tongue base just with continuous coblation technology. Erica Taylor at Pennsylvania removes a large segment of tongue base with a robot. But my concern is, if we're removing a lot of the center of the tongue base, we are constricting the hypopharynx. So when it heals together, now we have less tongue base, but we have a narrower hypopharynx, and I've seen problems with that. So I think any overly aggressive resective procedure has been disappointing. I think we've gone from minimal to maximal, back to minimal. So I think that each surgeon should be comfortable with certain techniques, and I think we're still in search of that final solution.
Sure.
May I add a little bit? We have done just last year a case after everything. Tours in a very famous center elsewhere. He lost, thanks to Tours, not only body weight, but also his taste. And but his, as Michael said, this very important point, the daytime sleepiness, and so continued. And what we did, we provided him with a neurostimulation, and now he is happy. And therefore, it's just, you know, the long-term result is, as I am so happy that Michael said this, is not every aggressive surgery is on the long run good for the patient. And fortunately, we have now really advanced techniques with neurostimulation and so on, where we can help these patients definitively and do not bring them in danger. Is this English? Sorry.
There is one question from Dr. Vijaya in Chennai. Do patients complain of tongue pain after hypoglossal stimulation? And if it is present, how long usually it lasts in the tongue? Is there any pain?
They all complain, and it's interesting. They different sites. You know, some patients will. We do it as an outpatient, and they'll come back a week later, and some will complain of their shoulder hurting. Some will complain of the chest hurting. Some will complain of their tongue. But tongue is a common complaint. But these are temporary, so they're very temporary. When they once they heal, the stimulation itself doesn't cause tongue pain, but it causes a tongue awareness. Now, to feel your tongue being protruded is annoying, and it will wake you up. So again, that's the balance of having minimal protrusion so it doesn't wake the patient up. Now, in theory, if you think about it, we don't need the tongue to protrude. We just want to prevent it from falling back. So if we can keep it neutral, that's really should be enough. So in theory, it should be not that much stimulation. But of course, there's so many things we don't know. And what we cannot predict is the patient's sensitivity to this stimulation. In other words, one patient might sleep like a rock, and you could maybe turn up the intensity and he'll never notice it. Another patient might notice a very low intensity. But it's more that discomfort. Very rarely is there a pain issue, although we've had some. There are complaints, although overall, like Professor Harmon said, there is pretty good patient satisfaction, especially if you listen to the surveys that the company is showing. But overall, I have to say that it's most patients are okay with it.
When there is a continuous stimulation of the genioglossus muscle by the hypoglossal nerve, can it hypertrophy?
So Professor Herman is saying no. So of course, this is not continuous stimulation. Unlike Imthera is continuous, but rotating through different spots. And this is inspiration, stops, inspiration. Can it cause long-term injury? I don't think we know. I mean, it's been implanted for at least 6 years and probably longer for the clinical trials. So as far as we know, there's no evidence that it's causing long-term damage.
Okay. Dr. Vidyasagar, would you like to ask a question?
Thank you, Dr. Friedman and Dr. Carl Homan, for two marvelous presentations. Really fantastic. My question again to Dr. Friedman. I have been part of your journey in this search for the successful surgery for OSA. I think now you have found one, which is the hypoglossal implant. But my question is, how does the hypoglossal nerve that is supplying the tongue actually help in opening the velopharynx? That is number one. Number two is, with the classical intraoral pharyngeal surgeries, majority of the patients have the globus sensation. Does these patients with hypoglossal implant have the same problem yet or no?
Well, there are two good questions, and I can answer at least one of them. So 50% is not such a great score. So I'll answer the second question first. The answer is no, they don't complain at all of this typical globus or the mucus buildup that I think is related to the inability of the pharynx and the palate to clean itself. So that is not a problem. I was amazed by how much movement of the tongue brings the whole pharyngeal musculature forward and brings the palate forward, but it does. So trust me, when in 1995, I was very excited to do these trials because I liked new things, but I had very little confidence that it would work. And when we started Emthera, I was also excited, but very skeptical. So, but I have to admit, I think that it's very impressive that it seems to have a very significant effect both on the palate and the tongue. And I don't know if Professor Herman has any more scientific answer to tell us the anatomy.
As far as I know, some branches of the nerve are going into some muscles which are close to the soft palate. And if you just ask a patient to open the mouth and you press the tongue down, then you see how the soft palate a little bit comes forward, so that you can go with your, if you want, with your mirror or endoscope behind the soft palate. And that's my explanation for that. But we have seen it during artificial sleep when we go with the endoscope through the nose, and we do just this S-mark maneuver. We do it during the DISE, drug-induced sleep endoscopy, to see if we have a concentric or and so on opening and so on. That also a part of the soft palate moves with. That's our explanation for that. But it's a wonderful effect. If you stimulate the hypoglossal nerve, it opens up the upper airway. That's wonderful, not only the tongue.
And do you think in India we don't have the access to hypoglossal nerve implant? So do you still have to follow the old protocols, or can we do something like a surface stimulations? Is there any other research on surface stimulation, or your take on the myofunctional therapies?
Michael?
I don't know the answer. I think that the ability to certainly provide external power source is not new. I worked with somebody more than 10 years ago that showed me that technology, what the NIAC system is using. So I'm sure that your brilliant minds will come up with other options. I'm sure this will be not the only option. Once there are other options, I think the cost will be much more reasonable. Obviously, the cost for this electrode and battery is minimal, and the cost is related to supply and demand and the research.
And maybe just to support your argument, it is that you know that in dysphagia patients, they use the hypopharyngeal stimulation to help them to learn again to swallow and so on. And as Michael said, I think the new tools, if you combine it with any wearable technology and so on, will be a way. And the other thing is that I personally think that, like Michael, that Nyxoah, this minimal invasive procedure where you have only this incision and then you have everything from outside, it will be cheaper. And we all know that the price of devices depends a little bit on how many tools are sold around the world. And if they have now a CE approval, if they are able also to face the Federal Drug Administration, then it will be also available in India, because India, we all know, is an extremely rich country.
Thank you.
Thank you.
One more question from Michael Kahali from Brazil. When you have a non-responder to hypoglossal implant, do you remove the implant from the patient?
So the question was what to do with the non-responder?
Yeah.
Well, unfortunately, we've had non-responders, and two things happen. What we find is when the patient fails based on our sleep study, we encourage them to go back to CPAP. The majority will not go back to CPAP, and the majority swear that their Inspire is helping them. So they're very loyal to Inspire for the most part. Maybe it's Inspire marketing, but patients are very loyal to it, so they won't give it up. There are patients that go back to CPAP. The only patients we've reoperated are complications if there's a problem with the system, and we've had a few problems where the sensor went bad or the pulse generator went bad, but I have not done other surgery after Inspire.
Fine. One more question from Dr. Valerie from Belgium. In patients with nice nose, no tonsil, and a BMI less than 25, which technique do you use when you have a lateral wall collapse?
I guess the question is lateral wall collapse. And that's the procedure. If it's not severe, lateral pharyngoplasty is the technique that I use from mild to moderate. I guess severe, I would consider hypoglossal nerve stimulation therapy. It doesn't bother me that is lateral collapse. I'm assuming it's not concentric collapse at the palate. And I'm not totally convinced that concentric collapse at the palate is a real indicator of failure with hypoglossal nerve stimulation.
She has given two kind of patients. One is with mild snoring. Other patient is having severe OSAS. Only lateral collapse. She has given two scenarios. One scenario, the patient is having only a simple snoring, and the other scenario where the patient is having severe OSAS. So what will you do for that patient with simple snoring, and what will you do for that severe OSAS patient when there is only lateral collapse with the BMI around 25?
Now, I'm assuming that we're going to take hypoglossal nerve stimulation therapy out of the picture, and of course, for the snoring, it's not an issue. One thing we didn't talk about today is dental appliances, mandibular advancement devices. It's a very big part of our practice. It's very, very appropriate for many patients that have snoring and mild disease. And it's a non-invasive, simple option. So I think that's that would be a consideration. Would I do a lateral pharyngoplasty on somebody with snoring? I think I would consider it if I'm assuming they had some sleep apnea, mild, if that was their main symptom. Again, if it was somebody with severe and they're not a candidate for different reasons for hypoglossal nerve stimulation, then I would consider Z-palate, because in my hands, for patients with severe lateral collapse, that is the most effective.
Okay. Sima, would you like to?
May I just, because I want support Michael, the conservative option should be completely researched. For example, has this patient this problem only in the supine position? Can we help him if we change the supine position? I have a patient, a professor of chemistry, I have treated for 10 years time with a Cpap mask. Then we found out that if he has an oral device, he does not sleep in a supine position, he does not need a Cpap mask anymore. And that is not the solution for everything, but you can offer your patients non-surgical choices too. That's my.
That answers Valerie's question. Seema, would you like to add? You wanted to add?
Yeah, good evening. Compliments to both of y'all, as always. I've already seen Professor Harmon, so I have two questions, one to Dr. Friedman, one to Professor Harmon. First, I'd like to ask Dr. Friedman, and let me please allow me to make a fool of myself, because I'm known to sometimes ask very foolish questions. But there is something that's come to my mind. When you mentioned the fact that zeta palatoplasty, I am totally with you when you say that you do not want to advocate it for the very milder cases, but we want to use it for the mild to say moderate and the ones above that. Now, there is a section of the sleep world that is talking about doing MMA as a first option when you see circumferential collapse. And then if that doesn't work, you go into doing the soft tissues work, which you would otherwise have done before. Meaning thereby that the move is going more towards an aggression of surgery. Now, similarly, if I was to use the same analogy here with the palate, I would like to ask you, what would be your apprehensions for using zeta palatoplasty as your first surgery for the moderately and above the severe OSAs? I mean, I do understand that you do not advocate it, but the apprehensions why you don't.
Well, as you know, of course, there's never foolish questions, only foolish answers. Personally, I like what you mentioned that that some people are going straight to MMA. I've some good friends at Stanford, and for patients that need it, I refer to Casey Lee. There's other aggressive, both oral surgeons that are MDs and ENT and oral surgeons, that they look at MMA as their primary first-line treatment, and I have no problem with that at all. If I had a good, aggressive oral surgeon with experience in MMA in Chicago, I probably would send a lot more patients, because think about it. You have a space that is the retropharynx, retroglossal area. You have a space that's too small. There's not enough space there. So think about your house. If you don't have enough space, well, you have two choices. You can cut out part of your furniture and throw it out, or you can enlarge your house. Well, wouldn't you rather enlarge your house? So in theory, I love the idea of MMA. However, it's not popular because it's a long recovery. It's expensive and often not covered by our insurance, so people are reluctant. The United States has a great medical system where most people are insured, but Americans are also very spoiled. They expect everything to be covered. So it's not uncommon at all in Europe if a patient needs surgery and it costs them $20,000 or $30,000, they'll pay for it because they're used to it if they want to go to a private doctor. In the United States, if they have to pay a $20 copay, they're all upset because they have insurance. So it's not common here. So I'm not opposed to that, but I am more reluctant to do aggressive pharyngeal oral surgery because of, one, the risks of surgery. Unfortunately, when the robotic surgery became popular, I know of more than one complication that, with morbidity and mortality of deaths in postoperative period, either initial or somewhat delayed post-op. So these are dangerous procedures with risk of VPI, even though it's a small percentage. They're very significant risks. So that's why I'm reluctant. And I just have a lot of respect for maintaining normal anatomy. And it's like Professor Herman said too, it's like the beauty of hypoglossal nerve is that we are not destroying any normal anatomy. I don't, like I say, we have a long way to go. And I appreciate the opportunity to be to be part of this morning. So I want to thank everybody for allowing me to participate, and thank you, Professor Herman, for your words, and thanks to all the organizers and to Sagar for his continued support and effort over all these years. So we're very proud of you. We're very proud of our fellows. We're proud, and we know that you're the future leaders and sleep medicine, and you'll find the solutions that we didn't find. So thank you. Have a good night. And happy Father's Day.
Thank you so much. Dr. Ram?
Yeah, no question.
I think he had to leave. So if you don't, I'll take that second part of the question to Professor Horman.
Yeah.
It's a very simple thing. I remember in 2011 when I was with you, you were the only one who was advocating a lot of sleep endoscopies throughout the night. That lab of yours is phenomenal. I came back wanting to replicate it in India, but it's just not happening. Now, the problems that we were facing when we spoke at that time was the fact that the data that was being recorded through the night with every scopy was a huge amount of data on the servers, and you had like 20 beds at one time. With the advent of DICE and now DICE becoming so rampant, has your use of sleep endoscopy, natural sleep endoscopy, reduced?
In general, we do not do natural sleep endoscopy anymore because especially to select proper patients for the nerve stimulation, and we have done last year 60 in all my group, also the Sommer, who is now in his own department, and Heiser, who is in Munich. Altogether, we have done 300 hypoglossal nerve stimulation cases. And we found that the best way to select the patient is the drug-induced sleep endoscopy, because as Michael said, the problem with the concentric collapse is real. If you invest 30,000 euros or $30,000, you want to have a predictable result. And so the prerequisite is this drug-induced sleep endoscopy.
So natural sleep endoscopies are out now.
Yeah.
Thank you. Thank you very much.
Thank you very much, Mr. Holman. It's almost.
I also want to, if you allow, to say only one word. Thank you very much. It was a great, great meeting. Thank you.
Yes, thank you so much. Mr. Ambrish, to say a few words. Mike is.
He left.
No, your voice is not heard. Ambrish, Mr. Ambrish.
Sir,
Yeah.
sir, we're not able to hear you, sir.
Okay. With the technical glitch. Thank
You
you so
audible
much.
now?
Now we hear you.
Yeah. So before we conclude today's webinar, let me convey my heartiest thanks to Professor Friedman, Professor Holman, and for making the entire topic so interesting. Deliberation was so good, and I'm sure each one of us who watched the entire 2 sessions must be very, very grateful to each one of you. The topics were complicated. You have made it very interesting, very informative. Thank you very much once again. Thanks a lot to all viewers for sparing your valuable time with us this evening. And I'm sure each one of you must be having some more questions. So in case you have some questions, you can mail to Dr. Krishnan. I think Dr. Krishnan will be very happy to respond to you to every query. So with this, we conclude today's webinar. I'm extremely thankful to each one of you.
Thank you.
Thank you. Thank you. Thank you.
Thank you very much.
Yes, thank you.
Thank you.
Thank you very much.